Thank you, Dr. Jernigan. Closing our session and also joining us via Zoom from the Aloha Island of Hawaii is Dr. Joseph Keawe'aimoku Kaholokula. Dr. Kaholokula is a professor and chair of the Department of Native Hawaiian Health at the John A. Burns School of Medicine at the University of Hawaii in Manoa. Please give a warm welcome to Dr. Kaholokula.
Very much. Aloha, everyone. Sorry I could not be there. And mahalo for allowing me to be here and share with you some of the work we've been doing here in Hawaii. Next slide, please. First, I need to disclose. Okay, so you're on the disclosure. You see this disclosure screen right now? Okay, thank you. So I need to mention I have no actual or potential conflict. Just want to mention the funding sources for the research I'll be sharing with you from the National Institutes of Health. Next slide, please. I do make some assumptions that my colleague, Dr. Araneta, has already shared with you the epidemiology around obesity and diabetes among Native Hawaiian and Pacific Islanders. So I'll jump straight to the chase and begin to contextualize my talk in the larger social and cultural scheme of things. And for the sake of time, I won't go into all of this. Many of you are familiar with historical trauma as it relates to indigenous people, and the past transgressions against indigenous people have led to the inequities that we see today. What I do want to highlight are two things. One is the cultural determinants of health, which we believe are very important when addressing the health issues of indigenous populations, which are often unique to indigenous people. Aside from the issue of racism, indigenous people seek to revitalize their cultural language, their traditional languages, their cultural practices and institutions that once was part of everyday life for Native people. And for many of us dealing with health promotion in Native communities, believe that the return to some of these traditional values, practices, and modes of living hold the solution to addressing these inequities that we see. And the other point I want to make on the far right is that most of our interventions really focus on the biological, behavioral, and psychological determinants of health, overly so, and often, unfortunately, neglect these other determinants that are very much a part of this causal pathway. Next slide, please. Some of the factors that we know that are unique to social and cultural, are specific to the social and cultural determinants of health for Native Hawaiians that have been done with disaggregated data, meaning that Native Hawaiians have been disaggregated from the Asian and other Pacific Islander population, which is unfortunately the common practice in large epi studies. But what we do know is that Native Hawaiians are more likely to live in obesogenic environments where there are more fast food establishments, but less opportunities for physical activity. What we do know is that lower income and less physical activity in Native Hawaiians are associated with diabetes risk. And what we also know is that Native Hawaiians, on average, take in more caloric intake daily than other ethnic groups, mainly from local ethnic foods. And there's also lower consumption of fruits, vegetables, and legumes. There's also higher saturated fat and total fat intake. And another thing that we've learned from a study that has been done with Native Hawaiians is that Native Hawaiians who report high levels of overt racial discrimination are 3 times more likely to be overweight or obese compared to Hawaiians who do not report high levels of overt racial discrimination. And these are really factors that we need to consider. Next slide, please, in addressing obesity and diabetes epidemic in Native Hawaiian communities. This is an older presentation. Next slide, please. I'll skip this for the sake of time. So there are challenges with the prevailing lifestyle intervention strategies that here in Hawaii and the larger Pacific we are dealing with and trying to address. And one is that these strategies often neglect the social and cultural determinants of health. There's an absence of any social cultural context to them, making them unrealistic, unsustainable, and irrelevant to many of our people. They tend to be too intense, based on ideals rather than the reality of people. Many of you probably know Hawaii has one of the highest cost of living of all states. In Hawaii, many of our people work 2 jobs, multiple adults in one household just to make ends meet. So people often don't have time for complex and intensive interventions. Programs often are not easily accessible, thus, to those at risk because of that, and because most of them working 2 jobs, often working shift-type work, and their shifts often change from week to week, from month to month, making participating in intervention programs very difficult. Programs are not easily sustainable across different settings because of funding and other issues, and policies not in place often to support programmatic efforts. Next slide, please. So here in Hawaii, we've taken two approaches to addressing the issue of obesity and diabetes and other related obesity-related health inequities. And we take a culturally responsive approach. And really, culturally responsive interventions are on a continuum. On one end, there's cultural adaptation, or what is also called cultural tailoring. And on the other end is cultural grounded or ground-up interventions. Most often, like with the DPP, it's an evidence-based intervention, proven effective or efficacious in other populations and other cultural groups, and often adapted for new settings and new cultural groups. And often the adaptation takes two forms: surface structure changes or deep structure. Surface structure is very exactly what it is: surface structural changes to the name of the programs, terms used to represent local language, and the food and eating examples to represent the cultural specific preferences as well as geographical relevance. Deep structure adaptations tend to go a little deeper. Although like surface structures, the core elements of the original intervention are maintained and not changed. But with a deep structure, there's further adaptations made to incorporate cultural values, perspectives, if not practices. And at the other end of the continuum, which are culturally grounded, are really taking an existing cultural practice, perspective, worldview as the core of an intervention, at the heart of the intervention, and to address health inequities. Next slide, please. I'd like to begin sharing with you an 11-year journey funded by the National Institute of Minority Health and Health Disparities under their CBPR, Community-Based Participatory Research Initiative, called PILI, Ohana. PILI in Hawaiian means to come together or cling to. Ohana is family, both immediate and extended, hence represents the approach and philosophy we take of communities and families coming together to address obesity inequities. We had representation. You can see there from your screen. Here I would like to acknowledge our community partners. For the sake of time, I won't go into specifics other than to say they represent both Native Hawaiian healthcare systems, federally qualified community health centers, as well as grassroots communities with Hawaiian civic clubs. And Kula Nona Po'e Hawaii is a Hawaiian homestay community. And together, we spent the last 11 years developing, testing, both culturally tailored as well as culturally grounded approaches to address obesity and related disparities. Next slide, please. The first thing we needed to do is really understand the environment, the situation Native Hawaiian and Pacific Islanders were living in that addresses, that impacts their ability to make healthy lifestyle changes as well as maintain those changes over time. And as you can see here, there are both interpersonal, community level that emerged from our extensive qualitative research that was done that included over 300 Native Hawaiian and Pacific Islanders across different settings. And what we learned from them is what you see on your screen. Again, for the sake of time, I won't go too much into them. You have this to review back to. But other than to say, when you start looking at the community level, you start seeing where cultural stereotypes, role modeling, come into play, and access to culturally relevant activities and affordable, healthy foods. If you don't know, Native Hawaiians, Pacific Islanders are faced with numerous stereotypes from the mainstream. One of them you probably often hear is that Pacific Islanders are supposed to be big genetically. That's why we become great football players. But that's not true. That is totally not true. It has no biological basis as far as I'm concerned. It has a lot to do with some of these other factors that you see in front of you. And we needed to consider all of these factors in designing an intervention that would address obesity and obesity-related factors. Next slide, please. So we developed the PILI lifestyle program. It really was adaptation of the diabetes prevention program. We took off 16 lessons, condensed it into 8 lessons, maintaining all the core curriculum, delivered over 3 months. This is our culturally tailored aspect. But we knew that we needed to enhance that with a family and community focused component, which really became our weight loss maintenance phase. So the 9 months, the 3 months was spent with the DPP delivered over those 3 months, and then randomized into one of 2 arms in this pilot study that I'm presenting to you now, into a family and community focused weight loss maintenance component over 6 months, additional 6 months. And both interventions or both components were delivered by community peer educators within their respective communities. So it's community plays, and in group settings of 10 to 12. Community educators were trained in behavioral change and motivational interviewing techniques, and the intervention was also evaluated, or the outcomes were assessed by the community researchers themselves. Next slide, please. Next slide, please. Next slide. One more slide. Thank you, right there. I'm going to skip over, no, back one more, please. Culture adaptations. I'm going to skip over some for the sake of time. The other two slides showed the breakdown of the lessons, which you can see with being that the slides will be given to you. What I want to emphasize is some of the surface structure and deep structure modifications we made that we felt was really important in making the intervention community and culturally relevant. One was we changed a lot of the pictures and images that you would expect. We use words and terms and food examples specific to Native Hawaiian communities. But more importantly, we did some deep structure modifications. The DPP was originally individually delivered. We felt it was very important based on our focus group studies that we needed to do it in groups to capitalize on social support and role modeling. It was very important that community peer educators of various educational backgrounds were able to deliver this to make it accessible as well as develop capacity in these communities. But also community peer educators themselves are the cultural component of an intervention. They themselves come from these communities, are often of these racial ethnic groups, and they understand the culture and community context and assets that they can leverage for health promotion. The other thing we did with the DPP curriculum was take the core curriculum and then extend it out to family and community in the 6-month weight loss maintenance component, in which we asked individuals to really engage their families in these behavioral changes they were making, whether it was to get them on board with the same plan or whether it was to gain their support, but also utilizing community resources. Often these, as you saw earlier, they live in what we consider obesogenic communities where resources are very slim that would lend itself to a healthy lifestyle. But how do you make the most of what you got? Topics were also added to the curriculum that were very important to our communities. 2 topics were specifically added, one around economics of healthy eating, how to eat healthy within your budget, and talking with a doctor more effectively, very consistent with patient-centered approaches to healthcare, because our community felt that most of our participants took a more passive approach in working with their physicians. We wanted to empower them to work more effectively with their healthcare providers, and we incorporate that into our intervention. Next slide, please. Let me briefly share with you the results that we got. Now, what you see on the screen are results of just the first 3 months, the DPP translational piece, the 8 lessons, but all 16 of the original lessons maintained and condensed into 8 lessons. These are across different studies over time that represent different samples of Native Hawaiians and Pacific Islanders. A majority of the sample in each of these 4 studies you see in front of you predominantly are Native Hawaiian. The other largest group is Chukis, a Micronesian group, followed by Samoans and Filipinos. We also consider Filipinos as part of the Pacific Islander category for our studies because they share similar health inequities. And as you can see, we were able, pre and post 3-month follow-up, able to get significant weight reduction, as well as improvements in blood pressure, physical functioning measured by a 6-minute walk test, decrease in dietary fat intake, as well as improvements in self-reported physical activity levels. And at the far right column, you see the average across these studies over the 3-month period. Next slide, please. But what I want to share with you now is the entire 9 months of our initial weight loss program that we compared. You may recall that I said our participants all received the 3-month DPP adapted component. After that, they were immediately randomized to either receive our family and community intervention as a weight loss maintenance program, or they were randomized into a standard behavioral program that consisted of phone calls, monthly phone calls, checking in with them and revisiting some of the original materials with them. So it was, in a way, another intervention that we're comparing to. The community felt it was important that we didn't have a true control group and that we compared it to perhaps what might consider some common practice. And what you see in front of you over 9 months is that our PILI lifestyle program really got significant weight reductions compared to the standard behavioral program group. Our initial weight loss target was a modest 3%. It was the minimum that other studies have shown to have clinical benefits, such as improvements in A1Cs and blood pressure. As you saw, we did have improvements in our blood pressure. That was realistic for our community partners, and they felt that anything higher at this time for the pilot would have been too tough. But as you can see, that over the 9 months, we got 51% of our PILI lifestyle program participants reached the 3% or greater versus only 31% of the other group. And on the right-hand column is really the 3-month to 6-month data of weight regain. As you can see, those who attended the PILI lifestyle program were less likely to regain weight compared to the standard behavioral group. Next slide, please. I can't go into too much detail in this one, so I'll skip this slide and revisit this in a discussion, hopefully. Next slide, please. Thank you. What I want to share now is another culturally adapted approach we took to diabetes self-care. And we adapted the Partners in Care, which has shown to be effective in American Indian populations as well as African Americans in other states. Dr. Keawe'aimoku Sinclair, who were part of those original studies, was here in Hawaii at the time and also led in this cultural adaptation and testing of Partners in Care. And Partners in Care, again, similar approach to the larger PILI lifestyle intervention that I presented to you. Next slide, please. What I want to emphasize is the cultural adaptations taken here that was unique. We did similar things that we did with the DPP, but what we did differently here was we took a storytelling approach, what we call here in Hawaii talk story approach, that really allowed the peer educators to use metaphors to link the participant's situation to effective self-management behaviors, depicting local characters at each lesson to reinforce traditions of families and communities working together, and to help facilitate communication and talk story amongst the participants of the groups. Next slide, please. Here are the results of that intervention over 3 months. It was a 3-month intervention based on ADA guidelines. And as you can see, we reached significant improvements in reduction in A1Cs. What I want to note, first of all, going back to the weight loss, is that the DPP has shown that for every 1 kilogram weight loss, it provides a 16% decreased risk for diabetes. And here what I want to note further is that for every 1% drop in BMI, there is about a 23% decreased risk for complications related to diabetes. So we feel that this 1.6% drop in A1Cs is pretty significant. Next slide, please. But when I want to spend the rest of I'm really running out of time here, but just briefly share with you a culturally grounded approach we're taking using Hula, the traditional dance of Hawaii, to address hypertension self-management in Native Hawaiians with hypertension. And I can't spend too much talking about Hula other than it's our traditional dance that we leverage for health promotion. Next slide, please. But next slide, please. What I do want to share with you, though, is the results, preliminary results. We're currently finishing a 5-year definitive study funded by the National Heart, Lung, and Blood Institute, excuse me. But what I'm presenting, I want to share that with you, but I can't. We haven't published the results, but all I can say is that's very similar to what I'm about to present to you now in a larger sample over 5 years of with Native Hawaiians. But here what you see is that under a Hula-based study coupled with very modest self-care education materials for hypertension management resulted in about 20 millimeters of mercury drop in systolic blood pressure compared to only 9 in the control group. We use a random waitlist control design here. So eventually after the 3rd month, the control group got the intervention. When we look at those who dropped greater than 10, versus those who did not, we see that 72% of the intervention groups were able to reach that versus only 39% of the control. And what we also observed were there were significant improvements in social functioning bodily pain associated with improvements in systolic blood pressure. But most important, I think from a cultural standpoint, and for some reason what we saw as a result of undergoing the cultural grounded intervention, we saw significant reductions in perceived racism in the intervention group between baseline and 3 months. Next slide, please. So a brief summary of our findings. The community place, culturally adapted DPP, for example, is effective, but the results are modest in weight loss, but it does improve also blood pressure, physical functioning, overweight, obese Native Hawaiians, other Pacific Islanders. Considering family and community context can improve weight loss maintenance. We observed, and I didn't get to present all the data here, but take my word for it, but and similar to other studies such as Look Ahead study or a program, we're finding that greater weight loss early on, the first 3 months, is significantly associated with longer term weight loss over 12 and 18 months. Greater participation leads to greater weight loss, basically the dose effect, more attendance, more participation, greater effects. And that the partners in care improves glycemic control and diabetes-related distress and self-care behaviors in Native Hawaiians and other Pacific Islanders. But also a culturally grounded intervention. What's more interesting here with the latter study I presented is that taking a culturally grounded approach can have both clinical, psychosocial, and social cultural benefits you don't often see with other types of more mainstream interventions. Next slide, please. And I'd like to conclude just with the lessons learned for you to consider. Peer educator characteristics are so important when doing community-placed interventions. We took a very strong community-based participatory research approach in addressing obesity and diabetes. They were part of the development and testing. They were the facilitators or the interventionists of the intervention. And we did notice that education level didn't really matter. We had educators who did not have college degrees versus those who were professionals, whether public health, social worker, nursing, or even dietitians. And we didn't really see that much of a difference across the communities based on those characteristics. In fact, what we did see was those with, I would say, with less education actually got little better outcomes, clinical outcomes, than did those with higher levels of education, and partly because they may have intimate knowledge of the community and better able to translate cultural assets into and leveraging those for behavior change. We did learn that one size may not fit all. We did see actually in our initial study that Chukis actually lost more weight than Native Hawaiians. So when you look at it stratified by ethnic group, Pacific Islander ethnic group, they did manage to lose significantly more weight over time than did our Native Hawaiians. And part of that, we believe, is because they're a smaller, close-knit community that still interacts strongly with each other. So the participants really engage each other outside of the intervention. Participant engagement, as I mentioned earlier, seems to really improve outcomes the more they participate, but we also included a lot of group interaction, games, and activities to keep them engaged and provide positive reinforcements. As I mentioned earlier, greater initial weight loss leads to greater long-term weight loss. In fact, most of the weight loss really occurred in the first 3 months, which leads us to really think about other strategies that might help to either enhance these adapted lifestyle interventions or replace them. And that includes an idea that we're currently entertaining here in Hawaii to develop a cultural empowerment approach, similar to what you see with motivational interviewing. As all of you know, motivational interviewing is used to prepare people for a formal intervention, and it has found to be effective for increasing the effects of an intervention around obesity. However, the effects are less when you look at people from minority status. So we think that a culturally empowerment approach, not necessarily that people who, indigenous people with challenging socioeconomic situations are ambivalent between the Mercedes or the Tesla. It's because they have real economic challenges that they need to face, and there's real stereotypes that create barriers for them in making those changes. So we believe culturally grounded approaches offer a promise to improving not only clinical outcomes, but social cultural outcomes as well. And what we did learn was greater attention needs to be paid on obesity prevention, because once they're obese, it's very tough for them to do anything else to reduce that. Anyway, thank you very much.